Welcome back to the Deep Dive. Today we're tackling a procedure that, well, it honestly keeps a lot of plastic surgeons up at night. We're talking about the vertical reduction mammaplasty, specifically the Hall-Findlay technique. And, I mean, the resistance to this technique is pretty fascinating.
It is.
You have one camp saying it's the only way to get real, lasting projection, and then this massive other camp of surgeons who are just terrified of it.
Terrified is exactly the right word. It's the ugly duckling phase that really scares people off.
Right.
If you're used to an inverted T, you close up on the table and it looks beautiful immediately. With the vertical technique, you close and it looks like a puckered mess at the bottom.
It does.
It requires a level of faith in the anatomy that just makes a lot of us, uncomfortable.
It's delayed gratification for sure.
Yeah.
But the critique usually boils down to two things, right? The fear that the shape won't settle right, and the revision rate.
The bunching.
Yeah, that bunching at the incision line.
Yeah.
But when you really look at the technique, the argument is that those fears come from a sort of fundamental misunderstanding of the word vertical.
Exactly. We get so hung up on the scar pattern, we think vertical reduction just means vertical scar.
Yeah.
But the scar is just the final footprint. The operation itself is a totally different beast. It's a specific combination of the skin resection, the pedicle choice, and this is the big one, the parenchymal resection.
So you can't just
The
take a standard reduction and try to squeeze it into a vertical scar.
Yeah.
You're going to fail. And that brings us to the whole skin brassiere idea. This is the dogma we really need to dismantle today.
Oh, absolutely.
I think most of us were trained on the idea that the skin acts as the container, for the breast tissue.
Which is a lovely idea, but biologically it's just nonsense. Skin stretches.
Of course.
The dermis is not a load-bearing structure. If you rely on a tight skin envelope to hold up, say, 500 grams of breast tissue, gravity is going to win. Every time.
And pretty quickly.
Usually within 6 months. The Hall-Findlay philosophy completely flips that. The goal is to shape the parenchyma, the internal architecture, so that it stands on its own. The skin should just drape over it, like a silk sheet on a statue.
So we're moving from packaging the content to actually sculpting the content.
That's it. And that shift in thinking dictates everything else we're going to talk about. The pedicle, the markings, all of it.
Okay, let's get into the anatomy then. Because if you're going to rely on that internal tissue, you need a blood supply that lets you move it around aggressively. The Hall-Findlay technique relies heavily on the medial and supraudial pedicle. Now, the inferior pedicle is the workhorse for most residents. We know it works. Why switch?
The inferior pedicle is great for safety, I get it, but it's essentially a tether. It really limits how you can shape that final cone.
Right.
The medial and supraumedial pedicles, they're based on a completely different vascular system. You're tapping into the internal mammary branches from the second and third intercostal spaces.
But is it as robust? I think that's the hesitation, You're moving away from that deep branch of the fourth interspace that we all know feeds the inferior pedicle.
It's arguably more robust if you design it right. This is where the details really matter. We're talking about a true supraumedial pedicle here.
What do you mean true?
To get that supero component, you have to extend the pedicle design past the 12 o'clock position on the areola.
Why that specific landmark? What's at 12 o'clock?
It's the descending branch of the internal mammary artery. It curves over the top of the breast and enters the nipple areola complex from above, about a centimeter deep.
Ah.
So if your design stops at 10 o'clock or 2 o'clock, you might miss it. If you go past 12, you're capturing that superior flow plus the medial flow. You essentially get dual arterial input.
Okay, so circulation is covered. What about sensation? The classic teaching is stay lateral to save the nerve. The assumption is that the medial pedicle just kills sensation because you're cutting right through that lateral line of fire.
That's the dogma. And it's based on this idea that the lateral branch of the fourth intercostal nerve just shoots straight through the breast tissue, but the anatomy is more nuanced.
How so?
That nerve has a deep branch that travels right along the surface of the pectoralis fascia before it turns upward toward the nipple.
So it runs under the carpet, essentially.
Exactly. So if you're doing a technique where you're just skimming the dermis, you might cut it. But the Hall-Findlay technique is about a full-thickness pedicle right down to the chest wall. You're lifting the entire carpet rug, padding, wiring, all of it.
That's a key distinction. You're not dissecting through the tissue.
You're lifting the unit. And the data supports this. In the series we're looking at, something like 85% of medial pedicle patients recovered normal sensation.
Which is actually higher than a lot of stats for superior or lateral pedicles.
It is. And that full thickness approach applies to the ducts, too. It's a numbers game. You have 25 ducts. If you de-epithelialize a bridge, like in a dermal pedicle, you're just transecting a lot of them. A full-thickness medial pedicle keeps those glandular connections intact. You're preserving the pipeline, which is why breastfeeding potential is better.
All right, let's get practical. You're in pre-op holding. You've got your marker. How do we design this?
First rule is throw away the tape measure.
The suprasternal notch measurement.
Get rid of it. The 21 to 24 centimeter rule is totally arbitrary. It ignores individual anatomy.
You mean high-breasted versus low-breasted patients?
Exactly. If you strictly use 22 centimeters from the notch for everyone, half your patients will have nipples pointing at the ceiling and the other half will be pointing at their shoes.
So what's the anchor point then?
The upper breast border. You have to actually palpate where the chest wall transitions into the breast mound. It usually aligns with where the striae start. That's your true anatomical start point.
And from there?
From that border, the ideal nipple position is roughly 10 centimeters down, along the breast meridian. It scales with the patient, not with some ruler.
Okay, let's talk about the skin pattern. The snowman.
Visually, that's what it is. You have a vertical ellipse for the body and a smaller circle on top for the head, which is the areola. It's not a keyhole shape. It's like a stacked figure 8.
Now, here is the critical part, and I think this is where the biggest marking error happens. The bottom of that snowman.
Cannot touch the inframammary fold.
Right.
This is the hardest thing to teach residents. You have to stop that pattern 2 to 4 centimeters above the existing IMF.
Which feels completely wrong.
Sure.
You look at it and you think, I'm leaving all the skin behind. It's going to be loose.
But you have to account for the physics of the closure. When you close a vertical ellipse, the incision lengthens. It pushes down. But more importantly, because we're resecting tissue from the inferior pole, the IMF itself rises. The fold moves up.
So if you mark all the way down to the old fold,
your scar ends up on the abdominal wall. It drops below the new breast footprint. And that is a disaster to try and fix.
So mark high, trust the drop.
Mark high. The closure will bring it down.
Okay, let's get into the OR. Talk to me about the pedicle dimensions. We're committing to this medial base.
The base width should be about 8 centimeters. Half of that base is in the areola, and the other half is on the vertical limb. And here's why we like the medial pedicle so much. It rotates.
As opposed to the superior pedicle, which folds.
Right. A superior pedicle is like a trap door. You have to fold it under and kind of jam it into position. A medial pedicle just pivots. It's a rotation. Much less tension on the vessels.
You've infiltrated. Any warnings about epinephrine here?
Yes. Be really careful injecting the pectoralis fascia. If you clamp down those deep perforators with too much epi, the field looks bone dry. And then you close, the epi wears off in recovery, and suddenly you've got a hematoma. So easy on the vasoconstrictors at the base.
Now let's unpack this WISE paradox. This is the core operative concept.
Yeah.
We aren't doing a WISE pattern on the skin, but
we are doing a WISE pattern parenchymal resection.
Break that down for us.
Imagine you have a stamp of the WISE pattern, the anchor shape. Instead of stamping it on the skin, you stamp it on the breast tissue itself, inside your snowman markings.
Okay.
You're going to remove the tissue that falls below and peripheral to that stamp.
So you're carving out a vertical wedge from the bottom and a horizontal block from the sides.
Exactly. You are conning the breast from the inside out. You leave the pillars, the tissue under the vertical skin markings, but you take out the bulk underneath them.
And what about lateral management? That's always the hardest part, that dog ear under the arm.
You have to be aggressive laterally. The Hall-Findlay technique really emphasizes that, liposuction is fine for contouring, but for the dense parenchyma, you have to excise it. You undercut that lateral skin flap and carve out that fibrous tissue.
And if you don't?
If you don't, the breast stays boxy. You completely lose that cone shape.
So you've done the resection. You bring the medial pillar, which is the bottom of your pedicle, and the lateral pillar together.
And you check for tension. The pillars have to come together without fighting. If you're struggling to suture them, you just haven't removed enough tissue deep down.
Okay, closure.
Yeah.
This is where the controversy peaks. Every textbook from the 90s, and a lot of current ones, say you need to gather the skin, do a purse string suture to shorten that vertical scar.
And Hall-Findlay says absolutely not, do not gather.
Why not? I mean, a shorter scar is better, isn't it?
Not at the expense of shape. When you gather the skin, two things happen. One, you get this pleating that takes forever to resolve. It looks messy. But two, and this is the real deal breaker, if you force a short vertical scar, say, trying to keep it to 5 centimeters,
Press the cone.
you squash it. To have projection, you need vertical arc length. That's just geometry. A B cup needs about 7 centimeters of vertical length. A C cup needs 9. A D cup needs 11.
11 centimeters is a long scar. That's going to be visible.
It is, but the trade-off is a breast that projects forward versus a breast that bottoms out.
Good point.
So would you rather have a long, fine line and a perky shape, or a short scar and a pancake?
Most patients would choose the shape.
Every single time. And the skin settles. But you can't recover projection if you've flattened it during closure?
Speaking of settling, we have to talk about the pucker, that dog ear at the bottom of the incision.
The bane of the vertical surgeon's existence.
You finish the case, and you've got this U-shaped bunching at the bottom. It looks like you just stopped too early. The temptation to taper it into a nice sharp V is just overwhelming.
Resist it. If you taper that into a V, you're extending the scar below the fold. You have to leave it as a U.
But it looks terrible on the table.
It looks unfinished. But here's the clinical pearl. That bunching usually isn't excess skin, it's excess subcutaneous fat.
So you don't suture it down.
Never. Never suture it down to the chest wall. If you do that, you create a permanent dent. You have to let it float. You tell the patient you will have a pucker at the bottom. It looks like a little knuckle of tissue. It will flatten out.
It does it.
It does, but it takes time, which leads right into post-op management.
Before we get there, let's talk drains.
No drains.
None at all.
Nope. The philosophy is that seromas reabsorb. Drains just introduce bacteria. If you have good hemostasis, you don't need them.
And sutures.
Monochrome Plus, the one with the triclosan coating, the data suggests it really reduces suture spitting and those little stitch abscesses. And given that the vertical limb is under the most dynamic stress, you want to minimize any inflammation there.
Okay, let's talk about the nightmare scenario. Nipple necrosis.
It's the worst feeling in the world.
You're in the recovery room. The nipple is dusky, congested, it's purple. What do?
You sit on your hands.
That is incredibly hard to do.
It's excruciating. But here's the reality. Necrosis is rarely a technical error you made in the moment. It's usually an anatomical artery. The blood supply just wasn't sufficient.
Right.
If you panic and take them back to convert to a free nipple graft, you are guaranteeing the loss of sensation and projection. You're turning the nipple into a skin graft.
So you just wait it out.
You wait. Most venous congestion resolves. If it's arterial, if it's dead white, it's probably gone anyway. But usually you just get some epidermolysis, the top layer peels, maybe you lose a partial edge, but the bulk survives. And you save the sensation.
Now back to that pucker. The patient comes back at 3 months. They hate the pucker. They want it gone.
You have to look them in the eye and say 1 year.
You make them wait a full year.
You have to. The vertical scar shrinks, the tissue settles, the fat redistributes. If you cut it out at 3 months, you're just chasing your tail. You create a new scar, new inflammation, probably a new pucker.
And if it's still there at a year,
then it's a simple fix. Local anesthesia, horizontal excision of the skin and fat, but honestly, most of the time, it just disappears.
it sounds like this whole technique requires a ton of psychological management for both the surgeon and the patient.
It really does. You're trading that immediate table perfection for long-term results.
So let's recap the major takeaways. We're stopping the markings high, 2 to 4 centimeters above the fold. We're using a medial or supraomedial pedicle to capture that internal mammary supply. We're resecting a wise pattern from the parenchyma to create the cone, but leaving a vertical scar on the skin. And we are absolutely not gathering that skin closure.
That's the summary. It's a shift from skin as a container to parenchyma as a sculpture.
And for the residents listening or the attendings thinking about switching over, the learning curve is real.
Yeah.
You will feel uncomfortable leaving that pucker.
Yeah.
You will feel nervous about those high markings.
But the payoff is a breast that still looks good in 5 years. And at the end of the day, that's what we're here for.
I want to leave you with one final thought to chew on. We talked about how the medial pedicle preserves sensation because it captures that deep nerve branch along the fascia. The data supports it.
Right.
So why is the inferior pedicle still the default safe option for sensation in almost every residency program? Are we teaching safety or are we just teaching habit?
That is the question.
Thanks for diving in with us. We'll see you in the OR.